with a camera in your face. But I've had people who will have a good intro conversation.
Mhm.
And then as soon as I turn the camera on, they turn into robots. And it's like, you don't have to, you can just talk exact. And then the camera goes off and they relax again. It's like, man, I need to like have hidden cameras so you don't know that you're being recorded. But
I'll try to not be stiff, but
yeah. Wow.
First podcast ever. So
well, welcome. This is like episode 98, 97 or 98, somewhere around there. So we're getting close to 100.
Cool.
But I could tell you, even after almost 100 episodes, it's still super awkward. So, so you said your son is 6 months old, right?
Yeah, 6.5 months.
Okay. Is there one thing that you think is super weird about being a mom that no one could have explained? Even if they had tried to explain it, you wouldn't have got it.
Yeah, I think there are a lot of things like that. A lot of things that I just think aren't explainable until you probably become a mom. I'll try to think. The things that come to mind, probably the number one thing is just kind of my racing mind now. I've always been, prior to being a mom, I feel like I was able to focus on a lot of different things, and just like be able to just chill and focus on one thing. And now being a mom, it's like I've had a lot more, I don't know, anxiety, intrusive thoughts, like a lot of weird things, like worrying about things, being up at night, just really hard to focus on like other tasks. There's just so much around being a mom. Like I'm always worrying about feeding, breastfeeding. Do I need to pump if I'm gone too long? What does he need now? Has his diaper been changed? Getting childcare, everything that I just obviously never had to think of before. And you just couldn't really have prepared me for that.
I've already forgotten, but at 6 months, is he already eating solid food or just breastfeeding?
It's still breastfeeding. We could start solid, so I probably will fairly soon. But we're on kind of a good routine right now, so just haven't really messed with it yet.
Yeah, I just remember that being an adventure. My daughter's first food was prunes. She was constipated and we were trying to get her going.
Oh, nice.
She really liked it. And I remember my son was really into pureed salmon when he was little.
All right. Good fats.
He doesn't eat anymore, but it was disgusting though to feed it because like it would get everywhere and there's oil in it.
Mm-hmm.
At least one time he sneezed it all over my face. So I could taste salmon. It was like in my sinuses. And yeah. So
the pureed meats, that's what it like recommended. And I was like, that sounds kind of gross, but
kids like them. I think the biggest change was their poop.
Oh yeah.
It's like changing a diaper when a kid's breastfeeding. It's not that bad. Once I start eating solid food, it gets.
So what I'm hearing is I should wait longer, as long as possible.
Yeah, if you like breastfeeding, I don't know.
Yeah.
It seemed like my wife was willing to have smelly diapers if she could breastfeed less.
Yeah, kind of wean off, get a little more freedom.
Yeah. Yeah, I just remember having like, even if the kids didn't want breast milk, just having to pump so that it would hurt. She got mastitis a couple times. So yeah, she had to stay very regular with that. And I think that was something that you probably couldn't have prepared us for.
Absolutely.
Just the intensity of breastfeeding, you know what I mean? With like a kid being hungry, or if the kid's not hungry, like having to take care of everything around it. So you've got to have the pump with you and it's got to be charged, or you got to find a place where you can plug it in, and you've got to have bags if you're going to store it. And there's just like, there's so many different things. And then if you're going to store it, like, is it a fridge? Is it are you freezing it?
Mm-hmm.
I don't know. And then are you going to heat it up again? That was a whole nother thing. Like heating stuff up. So do we have a bottle warmer? It was just like everything around that timeline is a blur.
Yeah, it's
Or I'm
so
so glad it's over.
overwhelming. Yeah. Yeah, absolutely. And it's funny because like Shiloh's sleeping through the night now, but like I guess that no one prepared me for that, or it didn't occur to me that I'll never be able to sleep through the night even if he does because I have to get up and pump. I can't
Mm,
go the whole night.
yeah.
So it's like still, even when the baby's sleeping through the night, it's like I still have broken sleep. It's crazy.
Yeah. Yeah. And I think some people, my wife wanted to hold on to breastfeeding as long as possible. And I think at some point with both kids, she just knew when it was time to transition them. I think for our son, he was just like, he wanted different things. He was never great at latching anyway.
Mhm.
That was always a struggle. And then so once he had a taste for solid food, I think it seemed easier. Our daughter was different, but even still, I think when you have a second, she's always trying to do what her brother's doing. So in a lot of
Mhm.
ways, she's been easier because she'll pay attention, she'll see what he's doing, and if he's eating something, she wants it. So she crawled sooner, walked sooner, started solid food sooner. Like all of her milestones came earlier. And I don't know if that's a hallmark of a second child or if it's a hallmark of a female versus a male, or
Yeah,
that's just the way those two are. But
that's interesting. Yeah,
she's always trying to copy him and keep up with him. So
I feel like I could see that. I mean, this is our first, so I'm hoping people do tell me they're like, oh, like you'll know, or it'll be kind of natural when he starts to wean and everything. But I have nothing to compare it to. But yeah, I mean, I have an older sister, and I know I was always trying to do everything she did
yeah.
when I was little.
What's
So,
your age gap?
um, about 2, 3 years.
Oh,
No, yeah, 2 years, and then my younger sister's only 1 year. So.
okay. So that's all pretty close.
Yeah, yeah, my mom, I know, I'm like, didn't even think about it at the time, but now I'm like doing the math. I was like, wow, my mom was a beast.
I I can't even imagine. So like if you're recovering from pregnancy within, so to have the kids less than 18 months apart, I don't even know, like, could you recover from pregnancy that quick? Or is she just like basically like a half injured athlete who's like, it's the finals, I'll get back in the game?
Yeah, that's a great question. I don't know. I think it depends on how you define like recovered.
Yeah.
If you're like back to your was she probably back to her pre-pregnancy baseline? I mean, I would have to guess not. But also does depend on if you're breastfeeding or not. Um, I mean, for starters, I haven't even gotten my period back, and I've worked with a lot of women who it varies a ton, but some women don't get their period back for a year plus, especially if they're breastfeeding. So,
Hmm.
and it's I mean, it's possible right before your first period, but generally, if you don't have your period, you're not ovulating, so you can't really get pregnant again yet. So,
I remember them telling us that, and I don't remember when my wife's cycle came back, but we were still kind of skeptical. She was like, I don't know. We're not gonna,
don't want to risk it.
yeah, I don't want to risk it because I can't speak for her, but I just remember her not feeling recovered. You know what I mean? A
Hmm.
second pregnancy close in close proximity would have been physically and probably psychologically a little too much. And then our daughter, we didn't realize she was really sensitive to caffeine.
Mm.
So she went through this period where she was just crying a lot. And we were like, we couldn't figure it out. And one of my wife's friends said, are you drinking coffee? She's like, yeah, I'm exhausted. Of course I'm drinking coffee. And she said that one of her kids had a sensitivity. So she cut out caffeine and it fixed the problem.
Wow.
So my wife cut out caffeine and perfect. So even with that being 3 years apart, I can't imagine had we had a kid, within 18 months and then stack that on top of it because it was a really intense 2 or 3 months
Hmm.
where she couldn't figure it out, tried all different kinds of things, pediatrician, everything like that. And she just talked to a friend who had been through something similar and just kind of off the cuff was like, oh, why don't you try cutting out coffee? And it worked. So
Yeah.
I don't
I mean,
know.
that's amazing, but at the same time, I'm like, whoa, she had to cut out caffeine.
Yeah. Um, but I think, when you're pregnant, obviously you go through a long period of time where you're cutting out you're having to give up a lot of things. And at that point, just not having our daughter cry all the time.
Yeah, worth it.
Oh yeah, she would
Mm-hmm.
have given up anything at that point.
Mm-hmm.
Because I think that was probably, other than like the lack of sleep and the stress, psychologically, just not knowing what's wrong with a newborn
Yeah,
was really tough on her. Um,
I feel that.
and it's hard on guys, but not to the same extent. You know what I mean? Like I don't have that. I didn't carry the baby, so I don't have that connection that you can't explain yet.
Yeah.
Like I've developed that over time as I've gotten to know my kids, especially as they've come out of infancy where we've developed our own relationships. And I feel a connection when they're born, but it's not the same, I guess. It's very different. I don't think it's as strong. Where I could hear the baby crying and I'm like, oh, she's probably gonna be okay. We just gotta my wife, it was like nails on a chalkboard. It was just driving her nuts.
Yeah, I feel the same way. And it's something about it being your baby too. Like yeah, just
Uh,
like it's like painful.
I have a funny story that she hates it when I tell it, but our daughter was sick one time and she had a pretty high fever, high enough to where we were a little concerned. I think it was like a Saturday or a Sunday. So she's like, call the pediatrician's office. They'll have someone on call. So I did, and I forget who I talked to. My wife is not thinking clearly. She's very stressed out. This baby is crying. She's got a high fever. Our son, I don't know how old he was, but he was misbehaving. It's a very stressful time. So I'm on the phone with this doctor and my wife's yelling at me like, ask this, ask this. So I'm asking these questions. I'm trying to stay calm. And she like comes over and she says, ask about swallowing magnets. And I'm like, holding the phone, like, what are you talking about? And she was like, I saw on Instagram that sometimes babies, if they swallow magnets, it can go in their intestine and it can like block them. If the magnet like pinches together. It happened to this one kid one time. And I'm like, I'm not going to ask that. That's insane. Like, that's
Oh my
crazy.
gosh.
There's no one, where did we don't have any magnets. And also, like, why would that explain, how would that explain the fever? And she's not like, she's pooping like crazy. Like, I don't think she was like, but there was no telling her. So I had to ask. And, the pediatrician was like, yeah, it's probably not what's going on. So anyway, our daughter survived, obviously. So now anytime something goes wrong with the kids, I'm like, well, probably magnets. you
Your
know,
poor wife.
I know. So it's like,
Intrusive thoughts are a thing. I mean, yeah, I look back on some things, maybe not to that extent, but that I like would like keep me up or would like increase my heart rate. And I'm like, wow, like the, it's like they're just like not super, it's like a phobia almost. Like
yeah.
it was not super rational. So,
But then, so working with women who are
mm,
going through this intense, probably in period, for some of them, the first time working on other things, but they're also having these intrusive thoughts and they have all these questions. I would imagine you get a lot of questions or fears or things that you have either gone through or completely new to you. How do you, if you're that doctor and you're sitting there and someone's like, you know, asks you a question and you're thinking like, that's insane, but you can't say that. You're
yeah.
saying you're thinking logically and clearly, and you have the education, but to that mom, it's a real possibility.
Hmm.
What if my kid swallowed two magnets? How do you even start to address that?
Yeah, for sure. So, I mean, I'll start by saying like I have a whole new appreciation. Like I've been, you know, um a doctor of physical therapy and worked as, in pelvic floor physical therapy for years now, but I guess I just had my first, right?
Yeah.
And I think I have a whole new appreciation for all of that stuff besides the physical recovery aspect, which was like obviously really helpful. I was able to help a lot of people, but um now I like get it a lot more. And I think I can probably handle and relate to um to new moms better because of that. But if I, I think previously if I got something and I knew it was like probably not or maybe not super rational, um I would try and talk through like all of it with them, see if it really was a possibility. But I was really fortunate where I worked at the time was I had a good network of people. Like I had lactation consultants that I partnered with and, you know, a couple amazing doctors and pediatricians, who else? Some doulas, just other care workers, OBGYNs that you know, when in doubt, I would, consult them or encourage the client I was working with to, ask them about it. But generally, if I knew it was pretty irrational, try and talk them down and um, kind of validate, but work through it with them. So,
Yeah. What's the most unusual question you've ever been asked?
oh gosh, um, most unusual question. I think I surprisingly would get a lot of questions around um like organs like falling, like worries about organs. And I get more of I would say like physical questions, like because I deal more with mom, right? Not necessarily baby. It's like I'm seeing someone in pelvic floor therapy.
Yeah.
But a lot around like feeling like are my organs gonna fall out of me, like,
Mm.
after this, like giving birth, or just in general feelings of heaviness, or like even I think the most unusual is I had a mom asked if like she was gonna like she was sick and she thought she's gonna vomit up like organs. So
Yeah.
that's not gonna happen. I mean, that's very unusual. I'd say that's the most unusual.
And I think it seems unusual for us as healthcare providers because obviously that can't happen, you
Yeah.
know. But for someone, if you think it's like the swallowing magnets thing, if it in your mind is an actual possibility or you don't know, like it could be,
Mm-hmm.
and
Well,
you fixate on that and it feels like that, it could cause a lot of fear and stress.
yeah, and it's actually not like it seems super unusual, but like the question about like organs or like fear of like losing organs out of someone's like vaginal opening is like I actually got that question a lot and still do.
Mm-hmm.
And I think it just comes from like a confusion around like how that works and like specifically like women with prolapse
Oh,
think that
okay.
that's like a concern. But it's not, but it's a good opportunity to like talk everyone through like what's actually happening. So
Yeah. What made you want to specialize in pelvic floor stuff?
yeah, so I actually coming out of physical therapy school, like I thought I didn't. We had just like a really short, we didn't even have that long of it was like a summer semester, like one class of pelvic floor therapy. And I always thought that it was like, oh, it's just like internal work. Like I have to do like internal vaginal exams and like um kind of in the conventional therapy. I remember um on one of my clinicals, like the pelvic floor therapist, they had like their own back room in this hallway, and like their patients went back there and like never came out till the end. And I was like, I don't want to do that. That seems kind of boring and weird to me. But I think it's come a long way. I learned a lot about it in my residency, which was actually more geared toward older adults. But then when I moved to North Carolina where I went to PT school and started a gym and clinic together with two other PTs. And we realized that it was a CrossFit affiliate, and there was a ton of women who were like, I didn't even know it was a problem at the time, like leaking, like,
Mm.
peeing themselves a little bit with like a lot of those movements, like weightlifting or jumping rope, running, that kind of thing. And it just seemed to be like the norm. And I feel like that's always kind of been the like, welcome to motherhood. You're going to like leak or have pelvic pain or something. Um, and there weren't really, it was a small area, there weren't any pelvic providers around. So I was like, okay, like this is a need. Like I'm gonna go, do a class. So I went, um, did a course, was able to start helping people in ways I'd never even thought possible. And it was the rest is history. I've like done just loads, like that's been all my continuing education since that time. And it's been really fulfilling. And I just, yeah, I don't know. It's been incredible to see people like get over that.
What's a common condition other than leaking that you guys see a lot of?
Yeah, I'd say leaking, I'd say like prolapse or like heaviness, pelvic pain. It doesn't have to be, it could be like internal pain, like pain with intercourse. But it can also just be like hip and pelvic girdle pain in general, like overall. So sometimes if it's like a stubborn thing that like classic orthopedic therapy can't solve, sometimes there's a pelvic component. I see a lot of people with just chronic constipation that affects a lot of things, low back pain. So I would say those are the major ones.
Do you work mostly with women after they give birth, or do you do like can you does it extend pre-birth, like when someone's pregnant?
Oh yeah,
Yeah.
definitely. I love getting people like either like pre-pregnancy or during pregnancy. Just because I think it's a great time to get a baseline, understand goals, especially for super active women who um you know like care a lot about maybe their athletics or physical things that they're doing and want to stay ahead of it. I love just getting that baseline. um, and there's evidence that doing pelvic floor muscle training and just like some, not a ton, but even just some visits of pelvic floor therapy prior to giving birth does decrease incidence of leaking and like diastasis recti, or just like that, issue of like the elongation in the center
Mhm.
of someone's stomach. And so that's, you know, cool to see. And I think it's just about helping people like learn about their bodies and prepping, you know, prepping for birth mentally and physically, and then making a plan for afterward.
So you could see someone basically through every stage of it: pre-pregnancy, during pregnancy, postpartum.
Yeah,
Yeah,
yeah, you could.
that's
Mhm.
interesting. How common is that to have someone stick with a PT through that? Because I feel like the stereotype of physical therapy is like you go when you're injured
Yeah,
or when you have pain or when there's a problem, but you're talking about almost being preemptive.
yeah, for sure. I mean, I don't get a ton of people who are like that proactive about it, and I get it, but I also it's not, I think a lot of people think of physical therapy as this thing where it's like you said, one, wait till I'm injured, but also like it can feel daunting because I think a lot of people's experience with like conventional physical therapy is like, oh, I have to like, go 3 times a week or like 2 or 3 times a week endlessly until like my insurance stops paying for it, or like they just tell me I'm good. Um, and that's not really the case. I'd say if I get someone who I'm going to get to see through like, you know, um, pregnancy, birth and beyond, like, we I tend to do a full exam and not try and identify all that, any areas that we could work on together, their concerns, goals, everything, make a plan and kind of go from there. And yeah, so you can do some preventative stuff, but also you can't chase everything in pregnancy. Sometimes it's best to kind of wait and see how it goes, but having a practitioner kind of on your side to like help as things come up, I feel like has been really valuable for people.
What's it like working with like an OB? If you have let's say you have a patient who you've been working with before she was pregnant, and then she goes and she gets pregnant, and then you have to interact with the OB. Are they accepting of of pelvic PT during pregnancy, or is it it's something that there's not a lot of interface between the two.
Yeah, I mean, I would say I haven't had a ton of interaction unless there's like a complication where I think it's super important to get clearance. I don't think like I think generally they're always cool with it and promote it, but it's not like a referral, you know, it's not like something that they think of. And I do think there's a lot of like, oh well, you're pregnant. So like you just have to like get through it. And so I think there is, I guess I wish there was sometimes more of a push to be like, well, why don't you go to pelvic floor physical therapy? I think sometimes people think, oh well, you're pregnant, so just wait till the baby comes out. Um, but overall, when I do have interacted with OBGYNs, it's been very positive. I think my only criticism sometimes is there's a lot of like outdated knowledge about like what is safe in pregnancy when it comes to physical activity um and sometimes advice is given with absolutely nothing to back it up, and I actually find it more harmful than helpful. So,
Do you think it's just a lack of knowledge and awareness from like the OB community on what you have to offer?
um, like,
Like it's pelvic floor PT something that's relatively new, and it's just like, hey, they went through medical school. It wasn't anything that was talked about, or is there some type of bias against it? Because it seems like if I'm gonna put on a physician hat, and it's like, okay, I'm kind of in charge of this, family unit that's forming, and I want everything to go well, and I want the
mm-hmm,
birth to go well, and if I'm there delivering, I don't want to have to do a C-section if I don't have to, and obviously as a doctor, you care about the health and the well-being of the mother and the baby, and you want everything to go well. And it's like, okay, well, I have a physical therapist in my community who specializes in making this transition and this process easier in ways that I don't have the skill or the time or the
mm-hmm,
expertise or any of that, to deal with. It would almost seem like a no-brainer referral. Like all of my patients I want going. Because it'd be like if a sport coach was like, well, I'm also going to be the strength and conditioning coach. Why? You know what I mean? Like your job is the sport, the tactics and recruiting players and doing these things. Do you really want to be in the weight room also planning that out? You go, that's why you hire, like pro sports teams will hire a strength and conditioning coach.
mm-hmm.
Colleges have that. So I would just think that a physician would want someone like you helping their patients. It just seems like it's almost confusing why it's not more common, I guess.
Yeah, I agree. I would guess it comes from maybe one lack of knowledge or understanding of what like can be done in pregnancy. Like
Mm-hmm.
I think there is an improvement in referrals in postpartum, which I still think could be better, but pregnancy, it's like not at all. And I think it's a combination of, you know, you only get like, I don't know, 10, 15 minutes with
Yeah.
your OB/GYN. And oftentimes, at least in my case, it was like when I gave birth, it was a team of midwives and OB/GYNs. And so I saw someone different like almost every time. And I think they just want you to meet everyone because they don't know who's going to be on call when baby comes. So I get that. But yeah, I don't think the continuity of care isn't always quite there. And then I think a lot of times it does just get in pregnancy, it's either like, oh, well, they're not feeling well, or we're not sure, or, um, wait till the baby comes out, I guess.
Yeah.
So, which, yeah, I don't agree with. I think outcomes are better with pregnancy or care in pregnancy. And that's not just like in personal opinion, like there's evidence to back that up, like I said earlier. So I do wish that the referrals were a little more automatic. And I'm not 100% sure why.
It's interesting.
Hmm.
I think most people, even if they haven't been to a physical therapist, let's say just say general physical therapy, they have an idea of what it would be like. You make a phone call, book an appointment, fill out some paperwork. there's some type of assessment, and then you have some rehab and soft tissue therapy, whatever. But I don't know, even for me, because I've never been to a pelvic floor PT, how is it different? Like, what do you guys like? I know you do like internal exams if you have to and things like that, but what does the process look like? Because I think there's going to be a lot of people, men included, who would benefit from it.
Mhm.
But like anything else, if it's so foreign and they don't have any concept of what's going to happen, that lack of knowledge and confidence is a barrier for a lot of people to even make the appointment to figure it out. So, can you walk me through? Because I've never seen a pelvic floor PT. Like, what's the process like for a new patient?
Yeah, for sure. And there's a lot of fear around it. Um, so, and I have to preface this with I'm going to talk about the way I do things. And there's a reason that I am not like in the conventional setting, you know, in the conventional insurance based setting. I've kind of set off on my own. And I think there's probably like with every um in every different type of health practice, there's, really good therapists and not so good. So I'll talk about the way I do it and what I think is should be best practice. But for pelvic floor physical therapy, usually, um, if someone wants to come in for an evaluation, we do intake paperwork, and I'll chat with them on the phone first for a good 15-20 minutes to see what the problem is, what they need. And we'll talk about if they want an internal exam. So that is usually what sets pelvic PT apart in one of the ways is that an intravaginal exam. So, that is meant to I insert a gloved finger to assess like the tone, strength, and just like muscle length, how they're functioning of the muscles of the pelvic floor. And that can be extremely beneficial for a lot of people. But it's not something that I have to do, or that, it's always number one is is patient comfort. So, I've helped a lot of people virtually and just without doing an internal exam, but I do think that's a good part of it. So we talk through that, the pros, cons, if that's something that they want in the exam. And if not, then usually first session we'll just do external. And that's going to look like, long subjective history. I like to get the full story of if someone's coming in for a specific complaint, what's going on, why, pain levels, how long it's been, what could be contributing to it. Um, and then, if it's just more for prevention for pregnancy, we're talking more goals and everything. Um, and then the full exam, like I said, it does depend on what they're coming in for. Um, but based on that, I'll do a full external exam where I'll assess kind of the whole chain. It's not just a lot of people think pelvic floor PT, it's just like look at the hips and the pelvic floor. Um, and that's not the case. And I think you can attest to that too as like a chiropractor and, holistic practitioner that there's lots of things that affect an injury or an area or pain. So um, we're looking at those areas as well. But we'll do a full exam. I don't know how in depth you want me to get on that, but then after that, get right into some treatment or some exercises, therapy, something that's going to hopefully help make a difference in session, and then talk about the long term plan, but hopefully be able to come up with kind of what's going on and why, so that we can make a good plan together.
So it sounds like someone comes in. You, I'm picking up on three different things that they're getting out of it. They're getting, um, ideally some relief, some
Mhm.
exercises, something that's going to help them. They're getting an idea of what could be going on.
Mhm.
So if not a diagnosis, at least like like a list of possibilities if you can't narrow it down.
Mhm.
And
And
then,
usually we can narrow
yeah,
it down pretty well.
okay. And then you're giving them basically like what a long-term plan would look like if they
Mhm.
wanted to keep going. So they're getting that short term, like this is the next step
Mhm.
that you would do, and then this is what's going on,
Mhm.
and then this is what a plan of care. So maybe even a prognosis, like you could expect to get better in about this much time. So somebody
Yeah,
could come in and have that experience and leave ideally with those things. Is that
for
a
sure.
good
Yeah, and I
summary?
can give an example. I think it was hard for me because it, depends on, the patient what they're coming in for. But say a mom comes in who's, I don't know, we'll say like 6 to 12 months postpartum, maybe has dealing with some pelvic pain and maybe some like leaking with impact exercise like running. I would like to do a full exam where we'd go through everything as all the way from kind of like breathing, seeing the position of, rib cage, is the core turning on, how is hip mobility and strength, like the deep hip rotators, even some areas people don't think about. Would love to still be able to do an internal exam to see how are those muscles functioning, depending on what type of birth, tearing, is there scar tissue, is the pelvic floor just really locked up from the trauma, or is it like loose, right? People just assume it's loose, but oftentimes it's not. um and then from there, do a functional exam. I might look at, if the athlete's a runner, like what is the form, where are the areas that they're lacking in that maybe is causing more pressure for them to be leaking. So it's not just about like, is my pelvic floor weak? Um, so I would try and identify those areas and see where's the problem coming from. And then from there, I can, prescribe exercises or do, tissue work, whatever's necessary to start addressing that problem head on.
I had a patient one time, I forget what she came in for. Not pelvic floor stuff, but she had pelvic floor issues. I was asking me questions about it. I think it was because I was working in low back pain, so it was related in a
Mm-hmm.
way. And I was like, yeah, I don't really know anyone in the area. I made some recommendations out of the area, and she was very skeptical about because she had already been to a pelvic floor PT, and they did not prep her on the phone that they were going to do an internal exam. And so when she got there, she just mentally wasn't ready for that, and then
Yeah.
went in and they kind of gloved up and just kind of went through it.
Oh.
And she obviously like signed a consent form and everything, and she admitted like she didn't say anything, but it was like she's like, I don't want to go back there. I don't like it. Kind of broke that
Oh.
trust. And I would imagine that they probably had a really good diagnosis and a really good plan, and she just didn't stick to it because there she didn't have that connection with a provider. So it
Yeah.
sounds like you spend a little. I would imagine they were rushed as well. I think it was an insurance-based clinic, but it sounds like you spend a lot more time prepping people, finding out what they want, and then kind of easing them into the process.
For sure. Yeah, that's my top priority. Like nothing is more important than that. Just making sure, especially with, it's such an intimate area and especially an intimate time, um, that that just has to be the number one priority. And, I just wish people would know, like, I think it's helpful. And but if someone doesn't want the internal, I'm not going to push it. Like
Yeah.
it's not that important. And maybe later, maybe visit 3, 4, or 5 when, you know, we're, better acclimated to each other. Maybe that's a time that, if we're not seeing the progress we want, or and they're more comfortable, it doesn't have to be on day one.
Yeah.
So, mhm.
I have referred one man to pelvic PT. Uh, what are the most common things that guys come in for? Because I don't think most people realize that you know that it's something that men would benefit from as well.
Yes, I would say I'm probably not the best to ask. Right now I really only treat women. I haven't had additional like um coursework in like male pelvic floor, but so I would generally refer that out. Um but I would say, sometimes similar things, constipation, erectile dysfunction, a lot with hernia repairs, which could also be in the orthopedic bucket too.
Yeah.
Um, and I'm sure there's probably more, but
Gentleman I referred to, it was pain in
mhm.
that area,
Okay.
but it was pain related to straining. So I believe we were working on shoulder issues, and it was a tendon. And so he was kind of, I needed him to push it a little bit. Like we really had to start getting some stress into the tendon. And that amount of like bracing, just he couldn't do the rehab effectively for the shoulder without addressing the pain in the pelvic floor.
Yeah. That's interesting you talk about the straining because I would say like bracing is like just whether you're male or female, knowing how to brace, which is not straining. Like straining's not what we want to do. Um, but yeah, that can affect both male and female, and I think is oftentimes a cause of many issues.
Yeah.
So
So how long do you spend with new patients? Because it sounds like that's a lot to get through in one.
yeah, for sure. So I do hour and a half to 2 hour evals. Generally hour and a half, but if I'm talking to someone on the phone and I'm like, wow, this is a lot, then I'll block 2 hours, but hour and a half to 2 hours, and then usually hour long follow-ups. And it's always with me, so I'm the same practitioner every time.
Okay. And then I'm assuming there's a lot of stuff people can do on their own. It's just, I think it's easy to picture orthopedic rehab. You know what I mean? You got stretchy bands and dumbbells and things like that. Is there any, how, how does rehab and soft tissue therapy work for pelvic floor? Is it a lot of the same stuff, just with a different emphasis, or are there totally different exercises?
It really just so highly depends on like what's going on. Because I truly believe like to be a good, pelvic floor therapist, you need to be a really excellent orthopedic therapist too. So, I was trained in orthopedics before pelvic floor, and they disguise as one another. I've had people come and see me thinking pelvic floor might be the culprit, and really it's more of an orthopedic issue, and vice versa, where, someone um has been referred because an orthopedic issue isn't necessarily getting better, only to find out that there's, pelvic floor involvement. So I guess I didn't really answer your question, but
No, it's situationally dependent. I
hmm
know that crossover between orthopedic and especially female reproductive, it's it's I've run into it before
hmm
where, I don't know. I had a young athlete, female athlete who was, I don't think I'd ever actually met her, but I knew her coach. And I got a call or a text message at like 5 in the morning, and then a call. And I think they were at some tournament or something. And she was having pain. And I think the tournament was somewhere local because they wanted me to see her. They were like, she has to compete. And I was like, what do you, like, what pain, like, what are we talking about? And it was a male coach. He was trying to explain, it was like lower abdomen.
mm
And the way he was describing it, I was like, I don't know what, like, there could be other things that I
hmm
can't handle. From what he was describing, this could be an ectopic pregnancy. She could have a ruptured appendix.
Yeah.
It could just be low back pain. She could have a cyst that, like, I have no clue.
hmm
And anything that I can deal with is not serious, but I just listed a couple things that
Yeah.
that could potentially, like, that
There's
are
so
going to
much in
need
the area.
surgery. And she, you know what I mean? Like, so go take her to the ER. He didn't want to, they obviously didn't want to do that. And I was like, if you bring her here to my clinic, I'm going to call 911, and I'm not even going to drive her because I don't want, like, just take her, have a physician evaluate her. And she needed an appendectomy.
Wow.
It's ruptured. But I think a lot of people don't realize that stuff in that area can feel like one thing, and it's not necessarily textbook. Like, the amount of burst appendix that I've run into that are not textbook burst appendix pain,
Mm-hmm.
where you're just like, that can't be. And it's like, they can get walled off. Sometimes it hurts, sometimes it doesn't. It doesn't. Sometimes it's like this chronic slow leak. And that's just something that's masks itself as orthopedic. That's definitely not orthopedic. I've never run into an ectopic pregnancy or anything like
Mhm.
that, but it's always like when a young woman is complaining about pain in that region and they come to me and they think it's low back pain or hip pain, I'm like, yeah, we're gonna have to be really sure about this before I start treating you. And because if it's something and you miss it and then you prolong and they don't get the
Mhm.
care, it I don't know, it can be, I don't want to say dangerous, but it probably could be dangerous, especially with
Yeah.
like if they go septic, if it's an infection.
Yeah, well,
But
it could be dangerous, but even if it's not dangerous, it's still a waste of their time if it's
yeah,
not like an orthopedic issue. So on that topic, yeah, I try. It's part of the reason, physical therapy, historically was like a bachelor master's degree, but now it's a doctorate, right? So we are direct access practitioners. So like you don't need a referral to go to a physical therapist, and that's because if you're a good therapist, you have been trained. And there's been a few times where I've evaluated someone and done some, and immediately was like, this is not acting orthopedic, right? It should be able to respond either positively or negatively to some tests or things that I'm doing in session. And so just having that knowledge and knowing when it's time to, treat versus, hey, you got to go somewhere else, is super important. And like you said, in that area, a lot of things could be happening.
do you get a lot of crossover with women who, they're dealing with the physical trauma of giving birth, and there's maybe also an orthopedic issue, right? You could have a disc problem and have a bladder problem and have pelvic floor issues. But on top of that, there's a whole psychological component to this whole process where there's just fear of pain or wanting to get her old body back or whatever else is going on. And then inevitably leading to like unhealthy lifestyle choices to try and speed up the process. I would imagine that your profession kind of selects for a lot of those. Like you have a selection bias where you're going to see a lot more of that. Do you see a lot of like disordered eating patterns and things that are almost working against what they're coming to you, like they can't recover if they're not sleeping well or eating well or doing those things?
Yeah,
Is it a common thing for you to have to deal with?
I'm actually like really glad you brought that up because I think when I like first got certified in like pelvic therapy and like went to go treat people, I was very much gung ho and like I'm fitness forward, I'm an athlete as well. And I was like, I was so ready and excited to like empower women to like keep going. Like a lot of these like you can get back to who you were and like what you can do and everything. And I still believe that 100%. But um I think the bounce back culture is not good. And I think it can be toxic in many ways. So I've like I find myself, especially with I think the population I see, actually having to like rein people in, like women in, more than like push them to do more, especially postpartum. And that was something that surprised me. Um, just because there is like it's so funny. It's just the mindset for a lot of women postpartum is just so different than like any other. It's like, I guess I'll give this example. Like if someone like tears their hamstring, right? It's like, or um they're probably going to expect like, oh, like they probably can't do something for a little bit. They're going to go to therapy. They're going to like, get better over time, or you know like they tore something, right? Like there's a level of tissue healing that has to occur, and a level of optimal loading that has to occur after that. And then it's like postpartum, it's like that isn't always respected, right, by practitioners, or there's not really no one gives them a blueprint or like, hey, go see someone for this. It's like you just tore vaginally or had this crazy birth, but it's like, we'll just wait 6 weeks and then do something. And um that just isn't a great game plan. So what I see a lot of is women who just like not sure how to start. So they either don't, or like they go from nothing to like, okay, I'm gonna jump back in now. And they went from 0 to 100 all the time. All the meanwhile, it's like they're breastfeeding and they need more calories, but they're so worried about losing baby weight, or just don't love the way they look in the mirror. And I get that. Like I've been there, still am there in a sense, right? Like I don't recognize my body like, I did before. And but not rushing the process is like a skill, and like, you know, helping someone like build that foundation is so much more important than just jumping back. But to your point, yes, I see a lot of just, you know, they're not thinking about that, like the lack of sleep someone's getting and the amount of breastfeeding and maybe not being able to meet their own needs because they're so busy meeting their baby's needs. And all of that affects healing and how their body's going to be able to respond to, whatever activity they want to do.
When you go through your history and discussion and everything, how in depth do you go into those other areas like food, sleep, stress, fear? I mean, these are a lot of uncomfortable things because I feel like, well, people don't want to talk about their emotions. Maybe they open up. They don't want to talk to me about emotions, but it's important. If someone's depressed, there's not a lot I can do with them for their mechanical low back pain.
Mm-hmm.
It just like that we can work on it, but it's slower,
Mm-hmm.
and they have to understand that association or understand that there is association. I don't understand why there's an association, but food is another thing. It's like it gets very touchy.
Mm-hmm.
People don't really want to open up about. They don't want to be judged,
Yeah.
and they don't want you judging what they feed their kids or what their parents fed them. But if you're not talking about fears, worries, stress, depression, anxiety, food, sleep,
Mm-hmm.
I think having tissue heal at a cellular level becomes really hard because those are all things that are really important for tissue healing, for optimal
Absolutely.
tissue
Mm-hmm.
healing. But on top of that, the tissue can heal potentially faster or better or be better conditioned if while it's healing, you're
Mm-hmm.
going through some type of rehab or exercise, but not trying to push too hard, but not trying to hold them back too much. It's like there's this seemingly impossibly delicate balance.
Mm-hmm.
How, and for you, it's got to be even more important, I would say, probably than, I don't know. I deal like a lot with like, yeah, you got a disc problem. It is what it is. But, your average person coming in with some low back pain and that's all they have, like a guy with low back pain is not like randomly peeing his pants. You know what I mean? Like
Yeah.
it's different and
Yeah.
almost, I don't know, potentially more intricate.
Yeah, I think it's extremely intricate and hard because I mean, just the nature of having a baby or multiple kids or, it like it changes week to week. I even tell people, I'll have people, that I work with like one week say, "Oh my gosh, I was able to, get 50 double unders today and I've never been able to do that. That was amazing." Like in jump roping. And then another, maybe like a week and a half later, they're like, "Why am I going backward? Like, I only got, 20 or something before I started like leaking or having pain." And what they weren't thinking about was like, "Oh, well, my baby went through a sleep regression and I got way worse sleep. Oh, I forgot to eat today, or I have not been hydrating, or like my stress level at work is like really high," right? All of that affects the bladder, your body, everything. You already know this. And I think it can be especially hard, especially in the postpartum period, because like you can't always control those factors as much. Like it's one thing to like pre-pregnant me to tell me to like, hey, like try to go to bed earlier, sleep in a cool environment, get off your phone, like, or like track, protein intake, like do all these things to try and make sure that you're not, like functioning at a deficit. But it's a lot harder when you're in charge of a, like, another human, or you can't always control those factors. So I think the best thing I can teach people, or the best skill I can help women with often, is just like um, reading that themselves and learning when to scale and when not to, and respecting their bodies and the healing timeline, and that it is like more up and down. But hopefully that we want the general trend to be up, but it's not always linear.
So it's guiding them through that ever
Mm.
changing landscape of healing and all, because I think people we often just think of it as like this biological explanation. Like, how long does it take for the cells to heal, to form new tissue? And it's like, yeah, you can put a window on that, but
Mhm.
it doesn't mean you're not going to have pain after. Doesn't mean you're going to be doing the same activities after, and it doesn't mean that you're not going to leak after and all these other things. Just because the tissue is healed or damaged doesn't necessarily give you an idea of function, doesn't necessarily give you an idea of pain or other symptoms.
Mhm.
And to prepare someone for that is impossible. As you said, it's like, what am I going to tell someone? Like, make sure you have enough protein. You know what I mean? It's That's so hard to do in the moment.
Yeah.
And then, but to be there with them, to be able to, as a clinician, to be able to guide them through that process when they're having a bad week. Well, what's going on? To be
Yeah.
able to think clearly and be like, okay, let's just analyze everything that's going on. And then someone like you, it's probably pretty obvious. Like, it's, these factors are definitely contributing to that. But the patient's not necessarily going to see that,
For
because
sure.
she's
Yeah.
living it. She's looking through life, like looking through like a paper towel tube. You know what I mean? Because
Mhm.
there's like work stress and baby stress and, husband stress and all this other stuff's going on. And just like,
Mhm.
you can't really see that stuff. It seems like that would be a benefit to have someone on your team, like being able to step back and look at the bigger picture.
Yeah, I think that's a big part of it, and I also tell people it's not the only part, right? Because like a lot of times, someone like they already know that, and like if we can't change some of those things, but there are huge mechanical factors that relate to a lot of people's issues, and it is possible to go from leaking to not leaking at all. And we've gotten there. I'm not here to sell snake oil. It doesn't happen overnight, especially if it's been going on a while. But um, I would say if it's issues have been going on, the longer they've been going on, the longer it takes to help, and sometimes it's not fully resolved. But if generally speaking, if someone does it the right way, builds the foundation, pregnancy and postpartum, and um yeah, I mean, I've seen a lot of people successfully, like, I just women can, give birth and build their foundation back, get to their pre-pregnancy level and better, and not have those issues. So,
Well, you're passionate about it
mhm.
because it works, right? Because
Yeah.
you've walked
Mhm.
people down that path over and over again and gotten those results. And I think for a lot of people, regardless of what it is, whether it's postpartum stuff or a disc injury, if you've never been through it before, or you've been through it and you failed, the outlook
Yeah.
is bleak, uncertain. You know what I mean?
Mhm.
You don't know where to go or what to do. And then if you do your own research, you're just inundated with way too much
Mhm.
information. A lot of it might not be bad, but it's not tailored to you.
Yeah.
It's like the top 10 exercises for leaking. None of them might be relevant to you because you might
Mhm.
not have that issue,
Yeah.
or it might not be the right time. Or I feel like a lot of times for orthopedic issues, when it's like the top exercises for whatever, they're too remedial. This is a great place to start,
Mhm.
but
Yeah, those are.
but they put them on there because they look good on Instagram and most people can try them and it gets, you know what I mean? They're not bad, but it's like, if you want to get back to running a marathon because you've done it before and you're doing something that's hard, and your rehab has not progressed to something that's hard,
Mhm.
and you're like, well, why am I still leaking? Why am I not able to run? A lot of times when people come see me, it's like, well, they're not, no one's pushing you hard enough. But it's not enough just to like, you know, throw them into the deep end and hope for the best. You do have to guide them step
Yeah.
by step, but there's usually that huge gap between where clinical care leaves off and where they want to be. And it's like, yeah,
Absolutely.
you've met all the requirements for a discharge. We technically can't bill your insurance anymore, or we've run out of, like, we only have up to 20-pound dumbbells anyway. So what are we going to do here? We've
Mhm.
reached our limit. even though the therapists or the doctors probably could do more in a different environment, it's just kind of where it cuts off. And it's like people are left in this void of like, well, I still can't do what I want to be able to do. So where
Yeah.
do I go?
Or even worse, and what's, you know, it's getting better, but what was common in, the pelvic floor world was like the amount of times that people come who failed pelvic therapy, like they failed their pelvic PT, or they just like it only got a little bit better. But when you actually question, well, like what was your therapy? And it was like just biofeedback and Kegels, like,
Mm-hmm.
well, that's not that's not gold standard, pelvic floor physical therapy anymore. Like um that's a place to start, but I mean, that's not where that's not where it ends by any means. And oftentimes, I mean, I don't even prescribe Kegels most of the
Mm-hmm.
time. So it just like that's not, if anyone's listening that thinks that that's like that's equivalent to pelvic floor PT, or that's what we do in pelvic floor PT, that's really not the case, and it really shouldn't be anymore.
Well, I think that's the problem that a lot of people have is like if you go to like a clinic that specializes in orthopedic, but they have someone who can do pelvic floor, you know what I mean? You get
Hmm.
those stereotypical exercises, which might not be bad, but you know, or maybe aren't. They only have a handful of exercises that they know how to prescribe because they're
Hmm.
not a specialist in that area. And I feel like that for me, referring people for pelvic floor PT, if it's not someone who specializes and that's like not what they primarily do, you know what I mean? Or it's
Hmm.
just kind of like a side thing that they could do. I'll still send people if that's what's available, but
Hmm.
I don't really have a lot of faith in it. Where every time I've sent someone to a physical therapist who that's what they do,
Hmm.
pelvic floor stuff, there's always a good result. It might not get the exact result that the patient wants, but that's the same thing with orthopedics. You know what I mean?
Yeah.
Like you're not always guaranteed to get exactly what you want, but I
Yeah.
feel like if you go to someone who specializes in it, you're going to get a result. And to
Hmm.
your point, if you're not getting a result, it might be something else. You know what I mean?
Yeah.
Where it's like, well, this might not be an issue where that could be handled by conservatively. Like maybe we need to bring a physician in.
Yeah.
Is that common for you to run into things and it's like, okay, this should have changed by now. We need to move you on to a higher level of care to figure out what's going on?
Um, yeah, that's happened a few times. I've had um generally the ones that come to my mind first are like severe hernias that maybe I had one woman who had a like a sports hernia, which are notorious for being really, like, I feel like even the orthopedic world doesn't totally agree on a definition for that, right? Um but um it was like this like weird vague hip abdominal related pain that just um was not getting better. She had been on a lot of fronts, and it's one of those things where it's like she did classic just like hip PT. She did um I think she might have seen a chiropractor for it. She like got x-rays and they had to do like a very special um MRI. Anyway, I worked with her prior, or like as kind of like she came to me and was like had low expectations and was like, I don't think you're gonna be able to help me. And we were able to like improve symptoms transiently, but after even just like 3 visits, I was like, I am not seeing what I want to see, and this is super vague. So, moved her on to like um a specialist, and I had guessed, I wasn't diagnosing, but I guessed maybe it was some weird, like maybe even like multiple hernias. And she had like two inguinal hernias that
Mm-hmm.
she needed a very special type of like imaging to see, and they did repair it. And she's not 100% better, but a lot better now. But there's just so much muscular atrophy because it went on for, I think her journey was like 3 years. So,
Hmm.
um, yeah, all that to say, you know, hopefully you get someone who can identify quickly if they need something else.
What's a good example of when if PT fails,
Hmm.
it doesn't have to, you don't have to look at it as like a failure, cross something off the list.
Hmm. Yeah.
And I think a lot of people will get frustrated with that,
Mhm.
but there's a lot of benefit to it because it's not prolonging care. It's like, okay, if it's what I think it is, it should get better within a certain amount of time. It's been 3 visits. We're not seeing any change. We need to move you on to higher level care. She gets the imaging that she needs,
Mhm.
which she might not have found otherwise. Like, it's almost like maybe she had to come to you or someone like you to fail some really good care to be like, yeah, we have to look into this to get the actual result that you want.
Yeah, and I mean, I don't see myself as like I'm a practitioner who hopefully is, I'm fairly confident. I'm confident enough that I don't want to waste anyone's time. Like it's my job not to like force PT to work, right? Like my job is to do what I know best, like the care that I can provide. But if that's not what's solving their problem, um, and I can and I know that or I can tell that, then like my job is to get them to the person who I think best can. So that's like I'm always trying, I want to figure out who the best person is for them. So
Yeah. Are there common things that women are worried about after they give birth, when they come to pelvic floor PT? I know we've talked about problems that they have, like leakage and things like that. But I think at least fear usually goes deeper than that. It's at least the orthopedic game. It's like, I'm worried that I have a torn meniscus. Well, why does that worry you? You know what I mean? What's behind that? Because like, that shouldn't keep you up at night other than the pain for a little while. But like, and usually there are deeper things. Like, and I attract people who want to stay active, and that's usually
mhm.
what it is. Well, I'm afraid if I don't get this taken care of, ultimately I'm not going to be able to either get back to my sport or get back to CrossFit, or for people who are older, like, be able to enjoy the last 20 to 30 years that I have with my grandkids and my husband, and to be able to travel and do everything,
Mhm.
in losing that autonomy. So I feel like for the things that I deal with, it's the fear usually goes deeper than what they think the problem is. It's what the problem and the pain is going to prevent them from doing.
Mhm.
Are there common things that you get from fears that you get from women that are much deeper than just like, oh, I'm afraid I'm going to pee my pants?
Yeah. Um Weirdly enough when you're talking about that, I feel like definitely more now, but sometimes it's a more even I don't know, it's almost more the opposite. It's almost w- like for so long there wasn't really great care um that I feel like women accepted the problems and like just kind of accepted that like they were going to have to live with that and this was like motherhood and maybe they wouldn't get back to um certain things or they accepted like okay well my days of running are over or I can't really do this anymore which I think is really sad so um that's starting to change but yeah I think when I am able to get someone to talk someone through that like they can get to those levels and like those are the fears it's like I think it's a fear of like yeah, if I have this, having a baby or I, do this, I'm not going to be able to like I'll never be able to like not wear a pad again, right? And that's like that sucks. I'm not going to be able to, you know, lift heavy enough or be able to go like do hard things with my kids, like go on hikes with them. I'm not going to be able to like pick them up and throw them in the air, jump on a trampoline with them. That's a huge goal I usually get. Um, And so it like runs deeper and I think there was just a long acceptance of like this is how it is. So, um yeah, there's almost like opposite.
That's interesting. Yeah, I feel like there are a lot of things that are maybe common, like they're common problems, but we don't need to normalize them.
Mhm.
Like, it's common after you give birth to wet yourself,
Yeah.
but that doesn't have to be the norm. Like, it could get better,
Yeah.
and I feel like a lot of times it's just like, well, it's common and it's normal. We'll just lump those two together, just deal with it. It seems to be that seems to be an issue for women. I don't know. I did a whole other episode on this previously with someone about that because I feel like my wife complains about that a lot. And women complain about it in general. It's
Mm-hmm.
like, oh, we just, doctors don't have a lot of time. And, it's like, it's common, it's normal. It's like, those two aren't always the same thing.
Mm-hmm.
Like low back pain, incredibly common. It's like 80% of the world's going to deal with low back pain. It's easy then to normalize it and just be like, you'll be fine. I
Mm-hmm.
think that's a hard thing as a clinician to, you know, to not do that, to be like, okay, well, it's common, but let's not make it normal for you,
Mm-hmm.
you know? And it's helpful for me because like for low back pain, I have chronic low back pain. So my empathy comes from the fact that I go through it.
Yeah.
So now for you having given birth, did that just like take you to a whole nother level of empathy and
Oh yeah.
sympathy? Cause like you've literally done it.
Yeah. I mean, I thought I was like, oh, well, I mean, I'm ahead of the curve because I'm already a pelvic floor PT. I mean, you couldn't have prepared me like at all. And I'm still dealing with stuff. Like I'm dealing with some of my own issues. One being pelvic girdle pain and adductor inner thigh related pain. And just having to, you know, follow that. It's like, it becomes, you know, running can flare it up, and I love to run. So sometimes it could be easier just for me to say, well, maybe I just will never be able to like run long distance again or something. Um, but no, I want to. I want to be able to do that. Even like, so I'm gonna create a plan for myself that I know will work eventually. And things take longer. Like it, everyone's just so different. And that's just so important. Like I didn't think I would be dealing with this at 6 months postpartum. And I've probably truthfully maybe over pushed myself a little bit here and there and set myself back a few times. Like I'll admit it. I'm not my own best patient. Um, but everyone's on a different timeline. I've worked with women, I think the fastest one girl was running 5Ks plus at like 5 or 6 weeks postpartum, which I was like, that's insane. But like we did, you know, I did very in depth assessments, return to run assessments for her, and I couldn't find a reason to limit her. So I was like, try it. And we built up to it and it was great. And then, other women, including myself, it took longer than I expected. Like it wasn't really running again until I was like past 3 months postpartum. So, there's just a lot of variation and it goes back to a lot of the factors we talked about that, but even things people don't think about in just someone's birth story, like how their birth went, plays a huge role in um how it's going to go postpartum, how active they were in pregnancy, how able were they to like maintain certain activity, running mileage, fill in the blank, that affects how they can get back postpartum as well. So there's just a lot of factors.
So do you have your patients make that wish list? Like, what do you like in a perfect world? What do you want?
Absolutely.
Yeah.
Yeah.
It's,
I love that. Yeah. I mean, that's where it's hard for me, like, how can I do the best care and, give them a plan if I don't know their, end goal wish list. So, yeah.
well, you say it like, how could I do it? But that's how healthcare is. Like, how often have you gone to a doctor where they're like, yeah, you're in pain, but what's your goal? You know what I mean? Like, it's just not a common thing that, or it's implied. It's like, oh, I'm assuming this is what you want to be able to do. But I don't know. I just don't think that with a lot of healthcare providers, maybe, I don't know. I guess we're all kind of trained to do it, but it's kind of like, this is a good thing to do. Let's move on. You know what I mean? Like, it doesn't, I don't think schools, maybe they don't have the time or the resources, or it's just not that important when you're going through grad school to really put an emphasis on like, no, if you really understand their goals and you really understand why that's important to them,
Yeah.
It's a whole nother level of compliance,
Hmm.
which means it's a whole nother level of buy-in, which means it's a whole nother level of results, quicker
Yeah.
results, better results,
Hmm.
and and better patient satisfaction just with understanding goals and
Yeah.
being goal oriented, not like pain oriented or symptom
Hmm.
oriented. It's just very, I don't know. I think that's something that maybe until you've gone through it as a healthcare provider, you can't really know. But then I feel like a lot of people are stuck. There's a lot of people providing care out there in the world that could be doing better if they were incentivized to or allowed to. I just feel like that's a common complaint that I hear from PTs specifically who have worked in insurance based clinics where it's like, well, I only have so much time. And then the PT assistants are the ones who have to kind of do this stuff. And I'm mostly here to make sure the billing and coding is good and that, I do the assessment, but not this other stuff. And, we double book or there's overlapping. So there's just like a lot of hurdles where even if you have like a physical therapist who wants to do a great job, knows how to do a great job, and definitely could do a great job, they're
Hmm.
almost prevented
Yeah.
in a way just based on the way the system is set up.
Yeah, it's really sad, and that's kind of why I got out of it. I was like pretty low, pretty depressed. Yeah, even in my last clinical first job a little bit, it's just hard. It is hard, and it's almost like you feel like you have to choose between like like giving your soul because or just like not doing good enough care, and then you just feel crappy because it's like, you know, my last clinical is like I had to see like 20 plus people a day. I only got like 8 to 15 minutes with them. And it was highly encouraged that I only do some manual therapy and then pass them off for like exercises with someone else. And it was like maybe like 30, 45, 30-minute eval, sometimes 45 minutes feels like complicated. And it just like, and then a lot of documentation. So it's like I have to choose between putting my computer aside and just like having a conversation and doing my absolute best work with every person, but then having like 3+ hours of like documenting at home or just like being glued to my computer for like every visit. And yeah, it just wasn't fun. And I'm not saying every clinic's like that. There are definitely still some gems, out there, but it makes it hard. The insurance reimbursements for physical therapy seemingly go down or stay the same like every year, whereas so it makes it hard to pay PTs well. It makes it hard for these smaller standalone clinics to make it work with just one-on-one care. So it's definitely a systemic issue.
And I think that's a good thing for people to know because if you're if you don't know anything about physical therapy, you don't know anything about healthcare, but you're a healthcare recipient and you have insurance, there's that question like, well, why would I not use my insurance? Why would I pay cash for something? And I think you just hit the nail on the head on one really big aspect of it is that insurance-based providers have all the skills. They want to do well, but they are within a system that only gives them a certain amount of time. And then there are certain rules based on the clinic because the clinic has to stay open and stay profitable. Where even if that clinician wants to spend more time with you, she doesn't necessarily control that environment. She can't.
Mm-hmm.
And so are you getting the care that you need? Maybe. But I feel like a lot of people will complain to me about failed physical therapy because of stuff like that. They're like, I only saw my PT. I was there for a certain number of months and I only actually talked to my PT a couple times. I was doing the same cookie cutter exercises as everyone else. I didn't, you know, I sat in the waiting room for longer than I talked to my my provider and there's just a lot of dissatisfaction and then they feel like that's just physical therapy. That's just how it is. So why would I go pay someone cash to have that same bad experience? And it's like,
Absolutely.
no, 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 no. You don't understand. When you step out of that realm and you get a physical therapist who doesn't have all of those limitations,
Mm-hmm.
you you get a whole, it's almost like a completely different profession. But then it's even very frustrating for people because if you don't have insurance or or maybe your insurance, like you have to, I don't know, reach your deductible or whatever before that starts covering it. And you go to a clinic that takes insurance. Well, their whole care model is set up around insurance patients. So they're not going to change it for you. It's not like you're like, well, I'm paying cash, therefore I'm going to get something different. It's like, no, they're set up a very specific way. You're just going to pay a bunch of money
to get the same
to
care.
get the same care. And if it works for you, that's great. Like if you can go, you have great insurance and you can get the results that you want for the cost of a low copay, and you don't need to see your PT. The PT assistant does a great job. That's fine. I just don't know that might be, maybe that's 75% of people. But what about maybe that's 99% of people. But what about the 1%? They're like, it just didn't work for me. What do I do? And it's like, yeah, if you go see a cash-based provider, not an insurance-based provider who takes cash, but someone who has just set up their whole system around not having to deal with an insurance company, it's like a whole nother, it's a very different experience. And I remember that um, I had chronic shoulder pain in the Marines related to like a training accident. It wasn't that bad, but it was like I definitely was hurt and on painkillers, and I went through a rehab, and this went on for years. And I came off a deployment and I was just like taking painkillers like crazy. Go back, check in, do rehab with a different base, doing different, but same stuff, see my PT. And I think at that, in the Marines, we use naval healthcare, and sometimes they have naval officers who are physical therapists, but then other times they'll have contractors. And I think we had contractors at that hospital. So I saw the PT barely ever.
Mm-hmm.
And then I would go through my rehab exercises. And at some point I would get released because I met all the requirements and I still was in pain. And then I would go back, and then I got an injection, and then it just kind of went through this whole process. Now, keep in mind, this is 100% free because the military is like socialized medicine. So it's like, I don't have to pay for anything, but I'm not getting the results that I want. And for me, I'm still doing everything that I need to do because I have to. But I just like, I can't sleep without painkillers. It just was like, and it had been going on for a long time. And every time I got a new episode of shoulder pain, it got worse. And this last time after I came off deployment, it just wasn't getting better. And usually it did. And I was like, okay, I got to do something about this. And so I ended up at a chiropractic office and I didn't know chiropractors could work on extremities. And this guy was a veteran, so we kind of vibed well. And I got a little bit of pain relief. And so I was more positive. And he only did manual therapy. And so I was like, okay, well, what's the next step? Because like this can't be everything. And he was like, yeah, you're gonna need some rehab for sure. And I don't know how to do that. Like that's not my specialty. And I was like, well, who do I go to? And he was like, I don't know. And I was like, okay, well, what do you recommend? He was like, well, don't go back to where you went before. I was like, okay. So I'm going to have to find someone outside of the military. So I started asking around, and I got referred to a physical therapist who she had worked with the Padres, San Diego Padres. And she had worked with their pitchers. So she's like she's really good. She's available. She's really expensive. She's all cash based. And I had to drive like an hour and a half downtown to get to her. I was like, okay, let's do it. And that experience was 100% different. Like it almost wasn't physical, like what I thought of physical therapy. And I had been through physical therapy for an ACL reconstruction, which was insurance based, and then this. So like my perception of PT was totally different. And I show up, and she didn't even talk to me about the pain. She was like, well, what's going on? What do you want to be able to do? Like she just kind of focused on like my goals. And for me, immediately it was like, can I sleep without painkillers? So we spent like an hour working on like a comfortable way for me to find a sleeping position. And I ended up going to Target and buying a bunch of pillows. And like, it wasn't anything about like, it was just like, how do we get this guy some sleep?
Yeah.
So it was like some mobility work, some soft tissue work, and then sleep posture. Okay, good. And then we started working on other stuff. And then she was like, oh, you had your ACL redone, your hip rotation. I guess they see it with pitchers a lot. If you can't rotate through, it'll end up putting extra stress on the shoulder. So it was like, okay, let's start to work on the hip and the shoulder. And it was just like, I would go in sometimes, I'd be like, it still hurts with push-ups. So we just spent an hour working on push-ups. You know what I mean? It was like one of those things where it was, it almost was a different profession. And it
Yeah.
would to open my eyes to it, where I would go and I went in and like happily gave her my money. And I had free healthcare, but I was getting results. And it was someone was actually listening to me and not being like, well, I have a preset set of exercises. And she was kind of artistic. And so she would like, as we were doing stuff, if it was working, she would kind of draw it like stick figures in a kind of creative way to like show me the exercises and then hand me that. So it's like she had no plan
Yeah.
necessarily going into the session. I'm sure she did to a certain extent, but it wasn't like she made a plan. Let's execute the plan. It was like, my assumption is she had like a general idea of what she wanted to do, but she was definitely willing to change that plan and adapt and create and do what needed to be done for me. And ultimately it worked.
Absolutely. Well, that's what needs to be done a lot of times is like I need to spend time with people because literally I might figure out during that session that like what I'm showing them or prescribing like I might be seeing a movement pattern and I need to switch it up or we need to address something else or I need, like it's just so different person to person. And I think it's so interesting that you mentioned like you started working on your hip for something seemingly unrelated. And I feel like that happens a lot in pelvic floor therapy. And it takes time with a patient to like kind of figure out those variables. Sometimes just because something's a pelvic floor problem, like just because it's showing up like that doesn't mean that that's like where the issue is happening, right? It could be down the chain, sometimes up the chain. So there's a lot of other factors, and you just can't possibly like I found that I couldn't possibly address that and like when I couldn't spend time with people. Like if I could only do a half, you know, like a crap evaluation, make a guess and then pass them off for weeks to someone else and it was like yeah, so I think that that's huge and very important for certain people.
Honestly, I would love to see the stats on it, but I think, and I don't know for physical therapy, because selection bias. People don't come to me because they have a successful PT experience.
Yeah.
So pretty much everyone who comes to me is talking trash about their previous physical therapist. But as a chiropractor, no one comes to me because they've had a successful chiropractor. So because I do mostly rehab and not a ton of manual therapy, my selection bias is like people come in, they're not happy with chiropractic and they're not happy with physical therapy and they need something different. And a lot of people are worried about surgery and they're all active. So like that, I've just narrowed down my demographic. But for those people, I think it's important to know that like you had a bad experience probably with an insurance-based provider. And I would be willing to bet, because I know some of these PTs and chiros that they talk trash about, they're good. Like they know what they're doing. They exist in an environment that restricts them, because I worked in insurance-based clinics and I'm sure there are plenty of people out there who I worked with over the years who think of me as a bad provider. And it's like, no, I knew in the time when we were doing it that it probably wasn't what you needed, but like I wasn't doing anything unethical. Everything was within the standards that was set by the insurance company, and it's what we got reimbursed for. And you had short times. I mean, I had 5-minute appointments that were double booked sometimes. So 2.5 minutes in and out sometimes with a patient over and over, 40 to 50 a day was where my quota, I didn't have a quota, but like that's what they wanted me to hit. So if you're my 50th patient on a Friday, and I've got 2.5 minutes with you, I would have to get lucky to have that actually work, So I would imagine from my experience that anyone who saw me as a provider in those environments, if you think of me as a good provider, that was like luck of the draw. You know what I mean? I would imagine that I have more unsatisfied patients than satisfied patients, just because of the environment, not because of like that's how I wanted to practice or I thought it was I was doing a good job. It was like that. I was going to do the best I could within 2.5 minutes when I don't know your name. And I probably should, you know what I mean? And luckily we had good assistants at those practices where like they were making sure that I was on the right chart. Everything was
Yeah.
good, but I was looking at the right x-rays and stuff like that. But the system, the insurance based system is not set up for success. So it's like, I feel like for a lot of people, if you're out there and you've, you're using your insurance and it hasn't been working and you're like, why would I go pay a bunch of cash to get the same thing? It's like, nah, it's almost a different profession. I feel like, and
Yeah.
that's from my experience as a patient and as a provider. It's very different.
Yeah. And not in all cases, but almost always, um, you know, I tend to say usually you don't even need, at least with me, I don't tend to see people as often or for as long.
Mhm.
Um, you know, I've like, yeah, we're not like milking insurance. Like I want to get you to where you want to be as fast as possible. So and usually you can do that because there's a lot more extensive home program and just more time together. So it's good.
Yeah, I think people value their time a lot. That's why I
Mhm.
find with cash based stuff, it's like they don't want to come see me very often, you know, especially once they start to feel better and they start to be able to manage it on their own. Because ultimately, that's what I'm trying to teach them to do. And it sounds like what you're trying to do as well. It's like, well, you might always have a leakage problem to a certain extent, but you got to know how to manage it. Like, it doesn't have to be, you know, if you keep up with your exercises, like if we find a routine that works well for you, especially if you're going to have more kids,
Mhm.
you know, it's probably going to come back again. But if you can find a way to deal with it now, you can do it the next time and you can do it the next time. And there might even get to be a point where you're like, I don't need any help for this. I know how to manage it.
Mhm.
And I love that when people are like, oh, like I haven't seen him in a while. It's like, how you feeling? Oh, I had low back pain last month, but I just went back through the plan that we did before and it's good. And it's like, oh, that's awesome. You know what I
Mhm.
mean? Because that's successful care when you need less health care and not necessarily more health
For
care.
sure.
So I think that that's another thing where, you know, insurance is, unfortunately, you get reimbursed for justifying putting more codes on a form.
Mhm.
And in order to justify that, you have to do more things,
And
not less things. You know what I mean? Like
yeah.
where I think with cash based stuff, it's like you can kind of, you pay a little bit more upfront for less healthcare in the long run, ideally, as opposed to if I'm an insurance based provider, you know, I kind of incentivized to run more codes. So to provide more healthcare, to do more stuff,
Mhm.
which is not necessarily the best way to do it. It's not always the wrong way, but I don't think people want that necessarily. Like you don't want to have to go more often so
Yeah.
that those
I mean,
codes can be
time's
run,
important.
yeah,
Yeah.
within a certain period of time where you can get that reimbursement, you know.
Mhm.
And then I run into a lot of people who complain about PT because they get like 12 visits a year or whatever. And it's like, yep, in January, I go back and I use my 12 visits and then I don't get, you know what I mean? Like it's almost like this thing every year. It's like they get this allotment and they never
Mhm.
really get the results that they want. They just kind of get a little bit
Mhm.
better. I don't know. And I'm not sure why it works like that, but people do use it that way. You know, I know a lot of people are like, yeah, for the last 5, 6 years, I go and I use my visits and then I run out and then I just wait another 9 months and then I go back and it's like, man, that's frustrating. But I don't think that they realize like you could actually just take care of this. Like this doesn't have to be a recurring issue.
Mhm. Yeah.
And it's frustrating from like a female standpoint. I can imagine if it's something like worrying if you're going to have to bring dry underwear
Yeah.
or wear a pad. You know what I mean? It's like
Mhm.
it's not like, oh, I might need a knee brace here and there. It's like, I don't know, I might need a change of clothes because I can't control my bladder.
Yeah.
That's a frustrating like thing to normalize. You
Absolutely.
know, I
Yeah.
just can't even
Mhm.
imagine, you know,
Yeah.
having to actually think about that.
Yeah. Um yeah, and like I said, it shouldn't be normalized. So I think that's also what surprised me a little bit was just that I think I had mentioned earlier, like the more chronic the problem, sometimes it's like not always like the perfect 100% result like that you'll get. But I will say, like in pelvic, more than any other area of orthopedics I've dealt with, like it has been more likely that I see a huge improvement even with something chronic, but I think that's more of a testament to it was never treated in the first place. So it's like not this in it shouldn't have been in this bucket of like chronic pain or chronic problem because it wasn't treated correctly. And so once we actually did treat something the right way, like it was totally treatable. It just was normalized for so long um that someone like they didn't go through the ringer. It was just like never addressed. So um
So a lot of women will see this as like Mount Everest, and you're like, nope, it's a normal size hill, and we can get there. It's not something that you have to deal with forever, and
Yeah,
maybe
a
they
lot
just
of
don't
times.
they
Yeah,
don't
and
realize that.
for sure. And I usually can uncover that after a good history taking, subjective, like talking through someone, seeing how they respond initially. I can usually give a better prognosis on that. I'm not saying it's 100% for everyone, but um, you know, really good results a lot of times, even in the case of someone who has had an issue for a long time. So
So pelvic floor PT, not scary, definitely
yes.
available. It can be what you need it to be, and it doesn't have to be these weird internal exams if that's not what you're ready for or that's not what you need. And it
Hmm.
does get results. So a lot of these issues that people are dealing with and they have been dealing with and they're afraid they're going to have to deal with forever might not be that. It might not be that might not be the case,
Hmm.
and I think there's just a lot of people out there who don't know this profession exists.
Hmm.
They don't know, even if you tell them, they have some misconception or a misunderstanding of what it's actually going to be like and what the results can be like. So I think it's important because even what we talked about earlier, a lot of physicians aren't necessarily aware of the benefit, and maybe a lot of times these things aren't available.
Yeah.
I don't know in this area other than you if there's anyone who actually specializes in pelvic floor PT. I think we have some, like I said, some orthopedic clinics
Yeah.
who will also take on pelvic patients, but I don't know of any
Hmm.
practices that specifically deal with it. Like that's their specialty.
For sure. And like in defense of physicians too, like it is relatively newer, like good holistic pelvic floor therapy and specialization in that area. So as clinicians like myself and others like need to be proactive about letting OBGYNs and other practitioners, especially in rural communities, know that like that is something that's available.
All right. Well, I think that's a good spot to end it.
Yeah.
Thanks for
Thanks for
coming on.
shedding light on this. Yeah,
Yeah, it was
appreciate
fun.
it.